and get started. I'm Trang Weidemeyer. I'm with the Oregon Cost Growth Target Program. Thank you all for spending the time and coming to this additional tag meeting this month. Just as a reminder, our regular tag meeting is at the end of the month, and it's on June 23rd. At the last tag meeting in May, after some discussion, we opted to hold this additional meeting in early June, just to have some more time to talk through some data submission template stuff. Okay. So I'm going to, as before, I'm just going to go through some of our frequently attending organizations. And if you are here representing the organization, please call out verbally your name so I can mark you down on roll call. As before, this Zoom meeting is being recorded and we will upload these to the Cost Growth Target Tag website. All right, so I'm just going to go down the list. Is there anyone from Advanced Health? All right, any people from All Care? And remember to take yourself off mute. Or you could insert it in the chat if you want.
This is Rebecca Owen.
From All Care?
Yes.
Okay, hi Rebecca. What about Anthem? Okay, going down the list. Any people here from Atrio? Okay, I'm gonna keep going. How about Care Oregon? Any folks from Care Oregon?
This is Peter Hedgecock.
Hi, Peter. Okay, Cascade Health Alliance.
KOW signed Wade Brown in Seattle. Governor Jay and the state legislature are fighting in court over
Any folks from Cascade Health Alliance? All right, what about Cigna?
Jean Wirtz is on.
Hi,
Jason Loftus is here.
Hi, Jason, got you both. CVS Health, Aetna.
Hi, Tracy Cole is here. John Novicus will be joining later.
All right, hi, Tracy, thank you. All right, First Health. Health Net.
Julian Duncan is on the phone for HealthNet and Julian.
All right, hi Julia, thank you. Humana, I see we have in the chat, thank you very much. Kaiser.
Hi, this is Keith Cronin from Kaiser.
Hi Keith. All right, anyone from OHA Medicaid, fee for service? All right, going down the list. Legacy.
Good morning, Daniel Porter.
Hi, Daniel. And Moda.
Yeah, hi there. This is Bill Dwyer from Moda.
Hi, Bill.
Hi.
All right. Pacific Source.
Hi, this is Jeanette Sims from Pacific Source.
Hi, Jeanette.
Kyle Hirata from Pacific Source.
Hi, Kyle. Thank you. All right, Providence.
Good morning. This is Drew Tarab from Providence.
And Kristen Downey.
Hi, Drew. Hi, Kristen.
And Jackie Favorite from Providence.
Okay. Hi, Jackie. Thank you. What about Regents?
Hey, good morning. This is Jared Collins from Regents.
And Vince Porter from Regents.
Hi, Jared. Hi, Vince. All right, Samaritan.
Hi, this is Trent Began, and it looks like Wade Penner is also here from Samaritan.
Okay, Trent and Wade, thanks. Trillium.
Hi, this is Sean Cratch.
Hi, Sean. Almost there. Umpqua.
Hi, this is Jameson Baird with Umpqua.
Sue Goldberg from Umpqua.
Jeremy Giordino from Umpqua.
Neil Vincent.
Logan Della.
All right, thank you. Yamhill CCO.
Hi, you've got Larry Soderberg and Amanda Champagne from Yamhill.
Okay, and United, skipped United. Anyone here from United?
Good morning, this is Anna Morales with United.
Hello, this is Peter Hindle, United.
All right, thank you. Are there any other folks who would be data submitters?
Trish Nimmelman, Health Share here.
Okay, thank you. All right. And from OHA, I know we have Sarah. And folks, if you're on OHA, can you write your name in the chat for me? To make it a little bit faster. All right. I know we have Megan from Baylit. Are there any other participants on the call?
Oh, Richard Gibson from Comagine Health.
Hi, Richard, thanks. All right, and are there any public attendees today? All right, I think that does it for intros. Again, and if you haven't done so at the beginning of the meeting, please edit your name in your Zoom chat to reflect your name and the organization you're affiliated with. And I'm just going to go over the agenda really quick. So today in our additional meeting, we're going to be spending a lot of time talking through some, continuing some conversations regarding how to submit data in the TME template. On the agenda PDF, you'll see we're going to update you on some specifications. We're going to talk about our thinking behind risk adjustment and truncation for this year. Zachary will talk a little bit about the standard deviation and variance, and we'll talk about how people feel about one or the either. Maybe it doesn't matter, but we do want to land on whether we're submitting one or the other. And then lastly, we'll talk about provider taxonomy for those service categories, including primary care provider taxonomy and behavioral health provider taxonomy. That came up in conversation last month, and it sounded like people were interested in having this extra category. So we're going to show you the list of provider types we have and get people's feedback on that. And then we'll have some time, hopefully, for Q&A. All right, I'm going to hand it off to Sarah to recap the May tag meeting. Thanks.
Thanks, Trang. All right, good morning, everyone. Thanks again for joining our extra tag meeting this month to get through some more of our topics on the data submission template and guidance. I sent out the slides and the notes from May 26th about half an hour ago. I apologize for that late notice, so I'm sure you have not had a chance to dig into the meeting summary, but just wanted to flag for you that that is now out. It's also posted online. If we missed any attendees, please let us know. We'll update that. And I also just wanted to reflect that at our May 26th meeting, we had a lot of discussion and we had a number of items that we tagged as needing more follow-up, whether that was internal or with this group. And we're not going to come back to all of those today. We're holding some of them for our second June tag meeting. So I just wanted to recognize that we have not landed everything. We didn't land everything in May, and we know that we have some unanswered topics that we are not going to get through today, but we do intend to get back to them in our second June tag meeting. So when we get to our open Q&A, we might come back to some of those unresolved questions from last time, but did just wanted to note that we didn't make necessarily a ton of decisions last meeting, but we did have some really good discussion and unearthed a number of options that we're going to continue to explore. So let's keep going and talk about the data submission template and guidance. So go ahead to slide 9, please, Michelle. We sent out an updated draft of the data submission template and specifications. This is dated June 3rd. We sent it out last week, and I sent it out again this morning. So you had it all for easy reference. We have not made any changes since it was sent out last week, between last week and today. So next slide, please. Just a couple of the changes that we wanted to highlight in this new June 6th draft. We incorporated a lot of the tag conversations that happened in April and May, and so hopefully you should see that reflected. We also built out a lot more of the content where there had been placeholders before, so even some basic things like definitions, things about the data submission itself, the timelines, requesting waivers or exceptions for data submission, all of that content has been filled in. But focusing on some of the more technical changes, we did add an icon throughout the document to indicate where payers or the data submitters have flexibility to use internal and existing methodologies. So this was a request that came up at the May 26th meeting to very clearly indicate where something is a statewide standard versus where payers have flexibility. So we've got this little dial icon or slider icon to indicate that flexibility. We've also added 2 new tabs into the data submission template and their accompanying specifications section to explain those tabs. One is a cover page. I think this is pretty straightforward. We had talked about this before. This is clarifying here's what's being submitted for which payer, which years, who the contact person is for the data submission. And then we've added a number of questions that are confirmation, maybe attestation is too strong of a word, but confirmation that the data submission does reflect the guidance. So for example, affirming that the data submission only includes data for Oregon residents. So yes, no. So there's a series of prompt questions that we'll ask each payer to complete before the data submission is submitted. This is something that we've seen in, I think, Massachusetts, maybe Connecticut as well, just sort of that affirmation that the file is ready to be submitted. So there's some new content there that we haven't really talked about. I don't know that it's particularly technical, but if anyone has questions or feedback, we can get to that a little bit later. We've also added a new tab for providers, and we'll talk more about this later in the meeting, but essentially we wanted to simplify some of the TME tabs where provider organizations were being listed. You might remember back in an earlier draft of the template, we had multiple columns for providers. So provider organization, provider name, provider tax ID, provider NPI. We've removed all of that into a separate tab, knowing that there might be some variation in how payers are reporting or what NPIs or TINs you have for a given provider organization. So separating that out to give some more space for it without bulking up the TME tabs. We've also added some more detail about attribution hierarchy, and we've also added some guidance that's specific for the coordinated care organizations and for PEB-OEB plans. So we're not planning on talking about that in more detail today, but those of you who are CCOs or have PEB-OEB plans, please take a look and let us know if you have any other questions about either specific payment types, specific benefits, specific inclusion, exclusion that we did not specify in these sections, and we will figure out if we need to add more content there. So that was just a really quick skim through the changes. Let's get into some of our detailed content. So the first is an update on risk adjustment and truncation. This was something we were originally going to start talking about risk adjustment at our May 26th meeting. We ran out of time and didn't quite get to it. So just to recap a little bit on the next slide, we've had a lot of conversations about what the best ways are to handle risk adjustment, whether or not we should consider truncating high cost outliers. This is something that the other cost growth target states are also working through. They maybe are making some changes for upcoming years as well. But we thought about this some more and have decided that we are not going to make any changes to the approach for risk adjustment or truncation for this initial data submission. So the data submission due October 1st. We think with our goal of finalizing the template and the specifications by the end of June, we didn't think that was enough time to really work through all of the considerations. And we also don't think that's enough time to align with where the other states might be going. So we might make changes to these areas in future years of the data submission based on the evolving conversation and definitely based on more conversation with you all. But we didn't want to delay finalizing our specifications or make any hasty decisions before we had really thought through all of the options. So we are not changing what we've already talked about for risk adjustment, and we are not truncating any high cost outliers in this data submission. So for this initial submission, payers get to risk adjust the data using your own risk adjusters, following the guidance and the specifications. You will tell us which risk adjuster software and version number is used, and we will come back to these conversations at a later date. Any questions or comments about this decision?
This is Kristen from Providence. I think it's just going to be helpful for us to know maybe what level of discussion will happen in terms of a validation process. I mean, I understand at some point you guys have to move, and that's totally understandable, but there's still going to be a lot of questions, I think, on a one-by-one basis, and just thoughts and openness to what that looks like, timeline for validation, etc.
Yeah, thanks, Kristen. I guess this is a preview for the very last slide. We do intend to start talking about validation as early as our second June meeting. And if not the second June meeting, then definitely the July meeting. That is our next topic as soon as the specifications are finalized.
Thank you.
Any other comments or questions?
Yeah, one question on risk adjustment. This is Jared from Cambia. Is it a requirement to use the same risk adjustment model for both commercial and Medicare, or is it possible to have a separate model for the two lines?
I think that we said in the guidance that the risk adjustment used should be appropriate for the market. So to me, that says you could use a different risk adjuster for the different lines of business, but Megan, would you clarify that for us?
Yeah, absolutely. It can be a different risk adjuster by line of business, so long as it's the same from the baseline period and the period that's being measured.
Thank you.
Mm-hmm.
Okay, let's start talking about primary care providers. So we have two topics, subtopics, I guess, here. And the first is affiliation. So for affiliating primary care providers to organizations, we have said, and I think this has not changed, that payers are responsible for affiliating primary care providers to provider organizations using your own methodology. Oregon does not have a master provider directory. We are not going to provide a master crosswalk of which primary care providers should be affiliated to which organizations. That will be up to you. So as I mentioned earlier, we do want some way to make sure that when we are compiling all of the payer data submissions, when we are compiling all of the payer data submissions across providers, we want to make sure, to the extent possible, that we're talking about the same provider, so that when one payer says, here's my data for provider 1, here's my data for provider 2, and then the second payer says, here's my data for provider 1 and provider 2, that's provider 1 and 2 are the same across. So this is what I mentioned earlier about stripping this out of the TME tab and putting it in this new tab 7. So originally we thought we would just say, okay, free text, write your provider organization that you're rolling everything up to. So maybe that's Legacy Health System as the full system, or Providence Health System as the full highest level of that roll up. And then we had a field previously that was just, okay, what's the NPI for that? And then we realized how silly that was. There was very unlikely that there was just going to be a single NPI or a single tax identifying number for a roll up to a provider organization at that top level of the roll up. So what we've done is broken this into its own tab and created more space to list out multiple NPIs or tax IDs for those provider organizations. So we're saying you as payers get to do all of the affiliation based on your own contract arrangements, based on however you're tracking this data internally, but we're asking you that when you submit the data, you help provide a little bit more supplemental information so that we know who all is included in that row based on the provider organization name. So we know that this is potentially creating some extra burden. We know that payers may not be able to do affiliation in certain ways, especially if there aren't certain VBP contracts or if there's some missing data. But we wanted to talk through what some of the risks are of this, or what some of the challenges might be in having the data submitters create this affiliation to provider organizations based on your own internal knowledge. Megan, is there anything you'd restate more clearly there than I just babbled?
No, I think you got it, Sarah.
Okay, great. So do folks have any immediate reactions to this topic?
Hi, this is Tracy Cole from Aetna. I just wanted to mention that we can, for a large enough provider, there could be hundreds of individual providers. I mean, I say hundreds, that's just a guess, but I'm sure that if the organization is big enough, there could be a large amount of individual providers and NPIs and tax IDs that we would have to list there. I mean, it's something that we're going to be doing for our own research anyway in order to map the providers, but it can get pretty detailed. So I'm not sure that that's a concern. I mean, once I start getting into it, then we would see what the top providers are, but it just comes to mind that there can be a lot of them to list there.
We agree. I think that's one of the reasons we wanted to pull this out separately. And so I think one place of potential feedback for all of you, especially as you're thinking about this internally, is we've just created a very basic shell template here, but is that the best way? Would it be better to just, give us a CSV file with all the NPIs? I think feedback on what the easiest way is to manage that information, because yeah, you're right, there could be hundreds of NPIs in a given affiliated with a given organization. Drew, what's up?
I think I would just like direction on, do you want NPI or tax ID? But I think, at least for a Prov health plan, we'd prefer to use tax ID. NPI often is like actually a little too granular for this exercise. And I think, I don't know if other carriers will find the same. The other thing that actually has crossed my mind is, and I don't know if this happens much in, let's say, like the greater Portland area or other metro areas within Oregon, but it's certainly possible that one provider will be like, if for maybe under like Prov Health Plan would be with like Providence Medical Group, and then under another carrier could be with a different affiliated group. I mean, their doctors moonlight.
Yeah. And I think maybe to both of your questions, where we're struggling a little bit is one, knowing that this will vary by payer and provider, but also trying to keep this at the provider organization level. So it's not the individual providers that might be moonlighting, it's that we want to be able to see, for example, Providence Medical Group, if Providence Medical Group shows up in multiple payer submissions.
Well, in that case, I think tax ID would be better than, well, anyway, I'd make my case for tax ID, but.
Okay. I'd love to hear from other submitters, because we've heard that this is a place where there could be some variation and not everyone might have tax ID, and we were going to leave it sort of open-ended, but what do you all think?
This is Bill from MODA, and I completely agree. NPI is not going to be helpful. Tax ID is the way to go.
Tracy?
Sorry, I just wanted to mention too, and I'm not sure, maybe I shouldn't be mentioning what other states are doing, but I know that we just got notification from, I think it was Delaware, that said that we've provided at the provider level in the past, but they didn't find that information helpful. So going forward, they're going to be doing it at I think it is the line of business, the commercial versus Medicare. So I just wonder if you were aware of that, or that has come up before.
Sarah, do you want me to take this one?
Yes, please. I was not aware of that.
So Tracy, as you know, there is some and actually a couple of you that are reporting to the 7, I think, states that have a cost growth or developing cost growth benchmark. There is some variation across the states. There's also some variation with respect to the organizing committees. For example, in Oregon, the implementation committee that designed these models and their desire to report at the provider level. And also there's variation within states in ability to do that because of lack of provider directory, for example, or really lack of penetration of total cost of care contracts, where you can sort of organize individual groups of entities into larger entities. And so so that always remains to be an option, Tracy, that there is no reporting at the provider level, but I think Oregon has made it very clear through their implementation committee and through the process that they have set up around accountability to be able to report at this level.
Okay, thank you.
Dean.
Yeah, I would just respectfully request that this tab be put in phase 2, and that you get your original submissions and see what you got. I assume NPI or tax ID is in the submission somewhere, and there's a public information available for OHA to query against a NPI file. So I would just request this tab be put in future iterations, and let's see what we get in the first round.
And Dean, let me clarify for that. We used to have a field in the TME tabs 3, 4, and 5, 2, 3, 4. That was a field for tax ID. We have taken it out and moved it here. So this is where the tax ID would be listed for each provider organization in the file. And we moved it because we thought there could be multiple tax IDs. Let's take NPI off the table altogether. There could be multiple tax IDs for a given organization depending on how this affiliation roll-up has happened. So we wanted to make more space for it rather than making the TME row even wider, if that makes sense. It's not elsewhere in the submission.
Well, then, again, I just respectfully request that it's this put in future iterations.
Okay, thanks for sharing. Other comments or questions?
This is Anna with United. Are you looking for a specific time, like a snapshot of at a point in time for this, or is it for each year? Because a lot of providers go in and out of some of the large provider groups.
That is a good point. I think we hadn't talked about that. I think we want point in time, but especially for this initial data submission where we have multiple years and there could be changes, would we only want to do point in time for the 2020 file, or would we want to have separate point in time for each of the 3 years?
Doesn't it need to line up with the experience?
It should.
So, I mean, it would be variable based on if the provider at the time of the service was affiliated with mega group X, then you'd report it X. And if they were at a different point in time affiliated with mega group Y, then you'd have to report Y. It has to be aligned with experience.
This is Bill from MODA, and I would say that I think that it would be okay to have the affiliations be just as a single point in time at the end of the entire period. And the reason I would say that is, especially if assuming that you are in agreement with just using tax IDs. Tax IDs don't split out, or if they do, that would be extremely rare. I mean, what happens is they consolidate. And so I think it would be probably fine if two groups got together and merged to show their experience as merged through the whole period, because ultimately they're going to be accountable for that. And then I would just further say that, I mean, the link between tax ID and organization name is pretty stable. There's some of those change from time to time, but if we get away from the idea that we're talking about NPIs, which is just a crazy amount of churn in that, and just talk about the tax IDs, then it gets to be stable enough where I think that would be okay. And also, in terms of just the number of organizations, I mean, the vast majority of healthcare organizations, they just have one tax ID. There are many of them that have more than one, but I just, that's small enough that I think that's manageable.
So can I ask, and I'm probably going to say this wrong, but I think when we were talking about it, we had some concerns that you're right, there's one tax ID for an organization, but what an organization is here, we might potentially be rolling out multiple organizations into a single organization. So, and again, this might not be accurate, but let me just pick on legacy again as an example. If we're going to think about, for the purpose of cost growth target program reporting and accountability, we will say legacy health system. That's the highest roll up. Everything gets rolled up to that line. But within that, there could be multiple tax IDs for the different legacy entities under that roll up. Is that accurate?
Well, this is Daniel. I can speak to that. I mean, that is accurate. I mean, we would like to see our 6 tax IDs that all have primary care in them rolled up into one legacy health that doesn't have a tax ID, for example. Well, it does, but it's not going to be on bills. But to Bill's point, even though providers move around in there, it's those tax IDs will still be affiliated with legacy health. And I think at the tax ID level, I agree in full with what he said.
So I think what we're saying is that in this tab 7 that we've added, we would want to see in the provider name column, which would be the provider name, provider organization name across the whole data submission in every tab, we would see legacy health system, or sorry, Daniel, whatever that top line is. And then there would be 6 tax IDs listed for that, for the 6 underlying entities. And that's the level of granularity we would see in tab 7, and that's it. I think that's what we're proposing.
We have 2 different issues going on here. People are talking about tax IDs. I realize that the tax IDs across the business units don't change, but as Drew said earlier, a given provider may move from one provider group to another during the year, meaning they're going to move tax ID numbers. So it's not an issue of keeping track of tax ID numbers. It's a question of you attribute provider A with tax ID 1 or tax ID 2, depending on when she was in tax ID 1 or tax ID 2. And I heard Bill Dwyer say, just do it at the end of the year, but we need to land that.
Drew?
So, hey, Richard, good to hear your voice. I was actually under the I think many of the carriers were under the impression, or maybe not the impression, but maybe we need direction. Can we do all of the measurements at the tax ID level? In which case you don't need to worry about, as a provider, moving between tax IDs. We're not even looking for that. We're measuring at the tax ID level to start with. I don't recall if the guideline dictates, is it measured at the human level, the human provider level, or at the tax ID level. So I guess we need a little guidance there. And if it is measured at the tax ID level, then, as Bill Dwyer has pointed out, it's a very slowly changing dimension. And a point in time at the end of the year, probably you're not going to gain much by, looking at anything other than sort of where was the tax ID at the end of the year.
So I think I want to keep us moving on this, and I think we need to just circle internally to make sure we're all talking about the same thing. I think there are multiple dimensions here, and we've got the attributing the member to the provider, which could change underneath the year. But then we've got if the provider is associated with a different organization, and if that organization is at a different tax ID. So all of those layers are rolling up here, and I think we can clarify in the guidance what we think makes sense. What I'm hearing, though, is that you collectively are expressing a preference for making this as high level and simple as possible, and that it's likely going to be tax ID and not NPIs for the purpose of this linkage. And I just want to restate, I think our intent in collecting this information is not to drill down and do tax ID or NPI level measurement. This is essentially a join key across the payer data submissions, so that we can be sure that when someone says provider organization 1, we are talking about the same provider organization when we aggregate the payer data for provider level reporting and accountability. So this is a validation check. This is an operational piece. It's not going to be exact. And I think, to Bill's point, that this is maybe stable, fairly stable over time, it should be okay to just do an end of the year snapshot point in time, because it would be stable and because we want it for the joining. But I also want to make sure we have time to think through any other of these implications you've raised. Is that a fair summary?
Sarah, I maybe have a question. This is Jeanette from Pacific Source. I feel like it's possible that the experience goes with where the provider is employed at the time. So if it's 6 months with organization A and 6 months with organization B, if the member moves with that provider and they're not affiliated with each other, it's possible that, in the experience, we're reporting 6 months for organization under organization A and 6 months under organization B. And just wanted to, so for me personally, I think the reporting at the end comment, I'm still aligning how that impacts that situation. And then also, it's possible that not all payers store the higher level organization. So if there's 6 tax IDs and there's 6, entity levels, it's possible not all payers store a singular sort of level that those 6 connect to within their systems. And so just wanted to sort of point out that to think about as well.
Thanks, Jeanette. Okay, I think we will maybe put a pin in this and come back at our second meeting. I do think that I'm struggling to talk about this clearly, between the difference between the member might move and the member months being separated versus the provider roll up separation. So let's keep going if that's okay. Okay, so the next thing we wanted to talk about was the provider attribution taxonomy. So 2 slides forward, please, Michelle. So payers must use.
Sarah, I don't mean to take us back. I just feel like I want to ask the tag one question so that we can have this offline conversation. So, so you all have contracts with these larger organizations, and underneath those larger organizations, there are entities that move around. Would it would guidance be enough to say to report at that TIN level according to the contract that was in effect during the time period of measurement? Or is that not specific enough? Or are there holes, or are there reasons why that might not work? So rather than saying as of December 31st, whatever year, report that TIN affiliation information, could we say report it based on the contracts that you have in place with these organizations at, during the year?
Megan, this is Drew. Maybe I think our more tangible examples might be beneficial. The words you're using, I think, still are a little bit ethereal.
Got it.
Drew Tarab is his attributed PCP is Sarah. Sarah, for the months of January to March, is affiliated with Providence Medical Group, and then Sarah changes affiliation to OHSU for April through December. And I've got experience with Sarah in both those two periods. What do you want us to do? I didn't change my PCP. I stayed with Sarah the whole time. Do you want us to report that as all OHSU? Do you want us to report it as whatever experience was with Providence and then whatever experience with the OHSU?
Yes.
The latter is probably easier for at least some carriers because Sarah's TIN would have changed. We
want the experience, the services, the cost that the patient or the member had, because this is about splitting the member. But if the provider changes, if the provider changes, sorry, never mind. I just broke my own brain. Megan, do you have?
Why don't we come back with like a tree diagram to map the conversation? Because I think what is happening is that how the spending is attributed to the organizations is coming out different than how the TIN is organized to these larger organizations. And we recognize that there's going to be some noise sub-TIN as providers move, come in, whatever. And so why don't we make that one of the first agenda items? And I would just offer on behalf of Sarah, if you don't mind, that if you have opinions or thoughts about this, to let us know so that we can map out specific examples.
Yeah, if people have scenarios or more specific feedback, please send me an email. That is incredibly helpful and not breaking any of the rules of the development process. Thanks. Okay, still talking about primary care, now talking about attribution of members. So payers must use a primary care-based attribution method to attribute enrolled Oregon resident members to specific provider organizations. Those organizations can be broad. There just needs to be that tie to primary care. So it could be hospitals with primary care or outpatient clinics. It could be the full health system at that highest level. It could be medical groups, et cetera. We're looking for that employer contract with primary care as the tie. This is a place where payers have flexibility of their choice of attribution methodology. And we recognize that not all members will be attributed for all payers. So on the next slide, we had previously talked about the attribution hierarchy that we want to follow. We've clarified this language a little bit in the updated June 6th guidance to be more explicit about this hierarchy. Sorry, my computer is not being supportive. Okay, so tier 1 is member selection. So members selected a primary care provider or a primary care home by plan design. So if that happens, that's tier 1. That should be the top line. Attribute all the members that you can in that way. Tier 2 is contract arrangement. So any members who were not attributed based on tier 1 would be attributed in tier 2 if there was a contract between the payer and provider for that period of time. So if there was a total cost of care agreement for specific members, those members would be attributed via tier 2. Anyone who's left after tier 1 and tier 2 can be attributed through tier 3, which is a utilization-based methodology. And this is where payers have flexibility. So totally up to you on how you do that attribution based on utilization. We do want to know how it's done, just so we can see how much standardization there is, if this is a place where we might want to make statewide improvements, but this is utilization based, and there are lots of ways to do that. It is possible that there will be members who are not attributed in any one of those 3 tiers. They will be reported in their own row as unattributed, and all of the costs for unattributed members will be reported together. So next slide. For tier 3, for that attribution based on utilization, we are providing some guidance in terms of provider taxonomy to identify who you're attributing. So sort of up to you on how you want to flag the utilization for this, but we are providing some guidance on the taxonomy codes. So there's a list of taxonomy codes in the draft specifications. That's table 3. This is based on the primary care spending report program taxonomy. We've made a couple of modifications to align with intent. The primary care spending report program taxonomy includes general psych, for example, and we removed that for the cost growth target program, but generally as aligned as possible. So as we were putting all of this together, we ran into some questions that we wanted to bring to you. So the next slide is, do you as payers have complete taxonomy code data in a way that will let you do this utilization-based attribution for tier 3? And is there anything that would prevent you from being able to report members that you attribute to primary care providers using utilization and a provider taxonomy? Tracy.
Hi. I think Meg and I owe you an answer on this too. I'm currently researching because for our other states, we only have about 25 to 30% population of the taxonomy codes in our claim data based on what we're using today. But I'm working with our APCD folks to find another solution for that. So I'm hoping that for this Oregon submission coming later in the year, that by then we might have more population, but probably still won't be 100%. So for the other ones, we've always created some backup logic to look at specialty codes of the providers when we don't have the taxonomy. So I think we'll be okay for Oregon. We're researching it right now.
Would it be helpful? So if providers, if Tracy, if you aren't able to fill in the gaps and you do need to start looking at codes beyond taxonomy, we do have a procedure-based definition from the primary care spending report to identify primary care. Would it be helpful to include that as sort of backup guidance, or should we just leave this to payers to use your own methods?
No.
Sorry, Tracy, can you say that again? You broke up for me.
Yeah, the procedures would be very helpful as a backup.
This is Anne from United. I wanted to just add, I think Delaware and Connecticut are both using procedure codes and place of service, and those are really helpful to us.
Yeah, Bill from ODA again. In terms of identifying a primary care provider, we've found that the taxonomy codes are not ideal from our point of view because, to give some examples, like an internal medicine doc may or may not be a primary care doctor. We have some providers that have some delegated credentialing, and they're just super irritated with us often by not getting right which of their providers are PCPs and which aren't, because they've got some of these more ambiguous specialties that operate all over their organization, but they don't refer to those people as primary care. And so in our credentialing process, we ask every physician, are you a primary care doctor or not? And there are a substantial number of to continue with the internal medicine example, a substantial number of those people that say, no, I'm not a primary care doctor. And they don't want to be treated as such. There's a bunch of other examples, but so if for when we're doing this, we would vastly prefer to rely on our own internal data on which of the providers have told us that they are a PCP versus the ones that have said, no, we're not a PCP.
I think if you have internal data and folks have self-identified as PCP, that feels like gold standard, but what do the rest of the program team think? Megan, Zachary, any major
Yeah,
questions with
no,
that?
I completely agree. If you know internally, you've already built your own data systems, and you can identify, oh yeah, here are the internal med docs who self-proclaim as primary care. Yeah, that should be the data source in my mind.
Okay.
So,
go ahead, Megan.
Can I just clarify something on the hierarchy with an example? Are you asking the payers if you have 10 people, and actually, Michelle, can you go back 2 slides? So if you have 10 members and 7 of them are tier 1 because it's an HMO product, and 6 of them are tier 1, 2 of them can be assigned to a primary care provider based on the contract. 1 of them can be assigned on utilization, and then the 3, if I did my math right, remaining go into the unattributed. Is that what you're asking folks to do, or are you saying if you have 10, slot them in and let us know, did you assign them based on tier 1, tier 2, or tier 3? And if you can't do any of that, then do the unattributed?
I think the way that we've updated the template, if I'm understanding your question correctly, is we would want the costs and the row, each row broken out for each of the tiers. So the costs for those 6 members who are in tier 1 with this provider organization would be reported separately from the costs for the 2 that are in the tier 2 for that provider organization.
So Acme Medical Group will have tier 1 members spending, tier 2 members spending, tier 3 members spending, yes. and then I'll just pick on Tracy. CVS Health would then have the unattributed members for that line of business.
Yes, that is what we are proposing.
Okay, I just felt like
and
we
this
needed
is
to clear
based
that up.
on. And this, sorry, and I probably should have given more context to this. This is a change we made after the May TAG meeting. Payers asked for this because the argument was that the costs and the trends for the different tiers could be significantly different, and it would be important to differentiate. Drew, you got your hand up.
I want to I think maybe confirm with you that this wouldn't be used to also then measure PCP spending, percent of spending that's going to PCP, because there's separate requirements for taxonomy.
Nope. This does
in
not
that reporting.
That. This does not replace that reporting and those separate requirements. This is only for the purpose of attribution. This is not for the purpose of reporting primary care spending statewide.
This is Daniel. I want to say on taxonomy that any NPI you have, you can map to a taxonomy, right? In the NPES database, those aren't fully updated, but they're pretty good. And I agree that taxonomy is not useful for identifying PCPs. What they are useful for is excluding specialists. So they can be used in that way. You can't tell if an internal medicine taxonomy code represents a PCP or a hospitalist or an ED provider, but you can certainly tell that an orthopedic surgeon is not a PCP from a taxonomy code. So they can be useful in that way, but again, not like an nurse practitioner. You can't tell. Right. So.
Thanks, Daniel. Question for Zachary, Stephen, Yishan. We originally had put the procedure codes for primary care identification in the specifications, and then we pulled them out in favor of just the taxonomy. And I'm not remembering why we did that. It sounds like we should put them back in. That's what I'm hearing today. But does anyone remember why we pulled them out in the first place?
Yeah, so yeah, we can put them back in as just kind of optional, reference tables for folks to use when applicable. I think we pulled them out because the definition for primary care for the primary care spending report is fairly narrow. I mean, there may be procedures that you're seeing in each of the payers' data sets that you say, oh, well, these kind of look and feel like primary care services. They're not on the official list of procedures, CPTs, for the primary care spend report, but it's not, this internal med doc isn't necessarily a hospitalist, so, or whatever the case may be. So I feel like it was just a little too narrow for this. We wanted to allow for more flexibility.
Okay, so I think what we're hearing, let me summarize, and then Tracy, I see your hand. So I think what we're saying is if payers have an internal data set of providers that have self-ID'd as PCPs, that's the gold standard, use that, totally. If you don't have a self-identification process or data set, but you have some internal definitions that you're already using, great, use that. If you are looking for guidance about who should count as primary care and you don't have that internally, we have this narrow definition from the primary care spending report that we can provide as an option or a starting place for you to use as some guidance. Does that make sense as sort of a hierarchy, a separate hierarchy?
I like it.
Great. Okay, Tracy.
I just wanted to say with Connecticut that we are just working on recently that we had some difficulty with the nurse practitioners and physician's assistants because they can be present in both primary care and non-primary care offices. So we had to do some hierarchy there and look at specialties for that as well. So I don't know if there's any guidance that you can provide for identifying those, but that would be helpful.
Thanks, that's helpful. I'm wondering if this is something that also would be payer specific, like if you figured out a way to do this internally that makes sense for you, great, or if this is something that we should try to get a little more standardized guidance for.
So I think just to connect the dots, Tracy, that there are two issues here and two different uses of defining primary care providers. One is to attribute members to those individuals. And so when you refer to the NPs and PAs, you may be affiliating or attributing members to those individuals, you may not. But then there's also how to define what primary care spend is in the primary care, like the professional primary care bucket, right? Actually, there's three uses. And then there's, in Connecticut, the primary care spend target, which is, scrubbing the data from that primary care service category. And so I think the question that comes up for you specifically is in that tier 3, if you have the ability to use the definition that Sarah is offering in the specification, you could attribute members using that. Otherwise, if they're not in tier 1 and tier 2, obviously, then they would go to the unattributed. So I just wanted to make it clear that we've got both the use of who's a primary care provider to attribute members to them, and then we have the use of the primary care provider to identify spending. And so I just want to recognize that there's those two different uses of this. And I think we may also have had a couple of different uses of that in this conversation too.
Thanks, Megan. We've definitely been switching between the two. We've tried to separate this out a little bit in the guidance. We've provided the taxonomy as an option, but I think we can update the guidance to be more specific about the suggested order of operations and then optional code sets if payers would find that helpful if there's nothing internally. Okay, let's talk about behavioral health taxonomy. So Megan, Michelle, if you can go ahead a couple slides. So last month, we talked about behavioral health and how to capture this, and we added a new service category for the claims-based reporting. This new service category is professional behavioral health providers. Sorry, Michelle, can you skip ahead a couple slides, please? So we had talked about this being a mutually exclusive category. So we would be reporting behavioral health This would be separate from specialists and other provider categories. We would be, originally, I think this would have been reported as either specialty or other. And so now we want to pull it out of those places and put it in its own category. Next slide, please. And that this is only professional services. So this is not a new field, a new service category. That's all behavioral health. So this is something we talked about again last month about the confusion here. Inpatient behavioral health services would still be reported as inpatient in the inpatient column, not in this behavioral health professional column. So this is focusing only on those professional services. And again, we know there's a little bit of noise here. This is not intending to create a summary report of all behavioral health spending, just like we just talked about with primary care spending. This is to create some additional separation between behavioral health providers and primary care providers and specialists. So we heard from you last month that it would be helpful to provide taxonomy codes to identify behavioral health providers. We have not put these in the specifications yet. We wanted to talk to you about them today. I want to add another bullet to the slide and actually say, based on the conversation we just finished, it sounds like we might actually want procedure codes as well to help with the identification of behavioral health providers, not just the taxonomy codes. So on the next slide, we've pulled a draft list of behavioral health providers. This is based on the behavioral health provider types in the Massachusetts definition, and with a couple of Oregon specific additions like the certified community behavioral health clinics, CCBHCs. So we wanted to gut check this with you. Is this the right list? Are there any behavioral health providers types missing here that we would want to include in this professional behavioral health provider bucket? Any reactions? I think I saw a couple thumbs up for the previous question. So I'm assuming that was about taxonomy and procedure codes. Yes.
Yeah.
Okay. Any concerns about this list? Anyone on here that shouldn't be? Anything missing? Anything else Oregon specific that might be missing?
Sarah, this is Jackie with Providence. Oregon has licensed professional counselors and licensed marriage and family therapists. And I see marriage and family therapists on this list, but not the professional counselors.
Okay, add that. Great. Okay, I'm just going to keep us moving. So we will build out the taxonomy for these and the think about some options for procedure code guidance. Again, I think this would be optional. If you've already got a way to identify this in-house, we would suggest using that. This would just be to help identify if needed. If you have more feedback on the behavioral health taxonomy, please send me an email and that would be helpful. But okay, let's move on to pharmacy rebates. Next slide, please. Thanks. Okay, so a little bit of context. We know that prescription drug rebates and price concessions are commonly granted. The effect of these rebates can be substantial, and if we're not taking them into account, our trend, our total medical expenditure, total healthcare expenditure reporting will not be accurate. So way back early 2020, the implementation committee decided that pharmacy rebates in the cost calculations. Check. That was fairly straightforward. On the next slide, we've started getting into the details about how the pharmacy rebates should be reported. So we've broken this into a separate tab in the data submission template. This tab in the data submission template is the source for pharmacy rebate information at the state, line of business, and payer level. We're looking to report this by line of business. We're looking only for pharmacy rebates attributed to Oregon residents. And this would include the PBM rebate guarantees and any rebate amounts transferred by the PBM. So I'm skipping over a lot of sort of what that is, but just to get to the main question that we have, which is on the next slide. And that question is, should we break out pharmacy rebates by category, or should we treat it as an aggregate category? And We originally drafted the guidance, and the draft guidance from June 3 is written with breakouts. And as we were talking about it this morning, we thought maybe we should revisit this question and think about if it's worth the lift to try to break out pharmacy rebates by category, knowing that maybe not all payers have the ability to break out pharmacy rebates by category. Maybe we want to talk more about the value of having this nuance in the pharmacy rebate data. And given that we're currently reporting pharmacy spending as an aggregate category, not broken out with this level of granularity. So let me stop there.
This is Greg with Kaiser. My first question would be, is the way drugs move between brand and generic and specialty, does it really give you any value to even try and do that, let alone the difficulty of doing it?
Yeah, I think that's a good question. I mean, we were inspired to even explore this breakout because it's something Massachusetts is doing, and it's informing some of their underlying reporting. This might be more advanced. It might not be worth the effort. Totally looking for your feedback on that. Drew?
I don't, Providence Health Plan's unable to report out rebates at this level. So we wouldn't be able to. Our rebate vendor wouldn't be able to supply this level at a sufficient level. It's a question. I have a side question related to rebates, which is, can you describe how the OHA might be taking the rebate information and allocating it, or as I said in another meeting, peanut buttering it back to the provider level trend information? In other words, without allocating the rebate information at the provider level, we would be potentially misstating provider trends.
Megan, can you help me with this one? I thought we had talked about not doing this at the provider level.
No state has been able to do it at the provider level. And as you know, Drew, it would be incredibly technically complex to do so. And so the other states are reporting state market and payer level trends net of pharmacy rebates, and provider level is gross of rebate.
Wait, the complexity part, I think, scratch. I'm not 100% sure I agree about the complex part, because every rebate would be tied back to a person, and every person is then either assigned or attributed to a provider group or unattributed.
Right, but I don't think any of the states, including OHA, are asking you to do that, which would then require you to see, Megan Burns is on these 5 drugs and we got rebates for these drugs, and this is the percent owed to Megan. And what you had just said is that your rebate vendor couldn't give you the breakout between specialty, brand, and generic. And so at least the feedback we've gotten in other states is it's highly technically complex.
Okay.
And so it's a known challenge to the data.
So, well, that leaves an open question for the OHA then. I mean, how do they, if you don't allocate it somehow, what is the caveat? I mean, because we're reporting at each provider level, we're then potentially missing a pretty large contra expense that could influence trend.
Do you pass the rebates on to the providers?
No, but this isn't about passing the rebates on to the providers. This is about reporting total cost of care at a member attributed level. So,
right. Well, this is about identifying trend at a provider level, at a payer level, and at the other levels. And
that's not correct, Megan. We're not measuring the trend at the provider who did the service. We're measuring the trend for the human and attributing that member to a provider. And so that's the basis of this cost trend growth. this is part of that. While these are dollars that are coming to us from pharmacy vendors, manufacturers, they're still potentially allocatable back to a human. And therefore, when we're driving, let's say Providence Medical Group's trends or Providence's trends, without including the rebate, you'd be likely overstating the trend. And I get the difficulty in breaking it out at that level. So what I'm just asking for is like, well, what's the plan? What's the OHA's plan then for noting that or peanut buttering it somehow?
Drew, I think this is probably something we're going to want to take offline and think about more internally with the team. I'd love to hear from a couple of the other payers if you have thoughts about this. I mean, I guess, not do you agree with Drew in that we might be overstating or understating? That seems straightforward, but how difficult would it be for you to report the rebates at to report the provider level information also net of rebates?
This is Dean and Dretta. That would be very difficult for us. We use a PBM, and as far as I'm aware, the PBM does not provide us detail to this level. It's on the slide, nor is it attributable to an individual patient. So we would have to engage the PBM to probably provide us proprietary information they've not historically wanted to provide on that one. So for us, it'd be no way.
Hi, this is John Navickas from CVS Health, and this would be a really tall ask in order to have us perform that. This isn't something that we would be able to perform very easily.
This is Anna with United. I want to echo that. This is a huge undertaking to get it at this level, and there are internal costs to us to get this reporting from the PBM.
And this is Chris from Advanced Health. To my knowledge, this reporting is not available from our PBM.
And just to clarify, sorry, because I know the slide is focusing on the categories, but right now we're saying, you're all saying that it's not, you cannot get the individual level rebate information from your PBMs, regardless of what category the drug was.
Correct.
Correct.
And Megan, I'm assuming this is what the other states ran into. Okay. Drew, I think we hear you. Let us talk internally and think about this and come back to this in the second June meeting. Okay. Any other comments or questions about pharmacy rebate reporting? Okay, then let's move on to standard deviation and variance. Zachary, you're up.
Great. So last time we talked about some standard deviation and variance, and it was a good conversation. Let's back up a few steps, and I want to ground us in the charge that we have before us. So last October, the implementation committee recommended a tiered approach to accountability, including reporting of performance based on statistical confidence. And this confidence, or the kind of the statistical testing, would be used to determine, accountability for performance against the cost growth target, and it would be kind of a foundational step before any accountability mechanisms would even apply, right? So if the percentage is greater than 3.4%, but we can't say with 95% confidence that it actually is, then no accountability mechanisms would apply. Let's go to the next slide. So, and then click one more. Yeah, thanks. So these are some graphs that we include in the, what do we call in that document? The user guide, data documentation.
Data submission guidance.
Submission guide, thank you. So I'm not going to belabor this. Everyone's familiar with this. Carrier A, they have relatively wide confidence intervals, but carrier B doesn't. So we know carrier B exceeded the cost growth threshold of 3.4% with 95% confidence interval. To know this, we need the risk-adjusted PMPM for both year 1 and year 2. But to do the confidence testing, we also need some kind of some notion of distribution, right? So we need either the standard deviation or the variance, along with the member month count. We've included the formula right there. Let's go on to the next slide. So just as I mentioned, it's 3 kind of ingredients to this cake that we're baking. Member month count, risk adjusted PMPM, and then the measure of how spread out the data are. So these are key components here. But we have a question before us. It can be either standard deviation or variance. From our perspective, we can calculate one from the other. It's not a big deal. It's just a matter of kind of operationally and just, I guess, administratively, just what's easiest for you all. Let's go to the next slide and let's talk about one point of conversation we had last time. Someone brought up the time frame component. Well, the standard deviation is going to vary. If you're looking at 5 years worth of data, that distribution looks one way. But if you're looking at 1 month of data utilization, that looks different. So we wanted to clarify that the data submission is specific to the single year and that cost distribution in that year. So that the cost growth performance is measured by comparing 1 year to that previous year. So year 1 compared to year 0 or 2 to 1, whatever it is. There's a bit of a curveball here in that this first data submission will look and feel really different because it encompasses multiple years of data. So that's just an oddity that we'll have to live with. But generally, the standard deviation or the variance for the given year should reflect the distribution of costs within that year. So year 2 distribution looks like this, and it's the cost distribution of year 2 or year 1 or year 3, whatever it is. Let's go to the next slide. So here's kind of the decision point as we see it. Either the SD or the variance is needed to conduct the testing for each carrier and large provider. Some express some interest in submitting the overall standard deviation or variance for all members in the line of business. That seemed to be mixed. Some really want to do it themselves. But that is an additional step that we could do. If we have the line level data, we can pool the variances easily and calculate the overall number. So here's our recommendation, and we want to hear what folks think, that carriers submit the risk adjusted standard deviation, not the variance, but the SD for each attributed cohort, so each row of data in the TME file, for example, along with the distribution of costs, the standard deviation for that unattributed row that we talked about a few minutes ago. And to kind of help convey what exactly we're looking for, we would provide some specific examples, some scenarios, maybe even some kind of calculator type tools with an Excel spreadsheet and additional details to help convey exactly what we're looking for here. Let me stop here and see what folks think. What's everyone's reaction here?
So Zachary, this is Jared from Cambia. I'm ambivalent to the standard deviation or variance question. It's like just pick one and we're fine with that. Yeah. I still have the same concerns about calculating a standard deviation or variance at a subpopulation level. I would prefer to have the same standard deviation for a line of business and apply that to all applicable rows or cohorts, just because when you limit the population, you just don't get all the potential variance that could exist.
So Jared, let me make sure I'm tracking. So you're saying instead of having a standard deviation for each attributed provider group entity, each row, there'd be one standard deviation for your commercial line of business.
Correct.
And that number would be applied to all the rows individually.
Right.
For each. So that's interesting. I mean, the one potential downside of that is you could have a large medical group that is a primary care medical group, and the distribution, although it's a small population, that distribution could look really different than another medical group, and so we'd be potentially holding them accountable when maybe that distribution is much wider than another distribution or than another provider organization.
Yeah, the challenge with healthcare data is that the tail has such a big impact on variation. So you either have something or you don't, and it's more random fluctuation than anything to do with the population. And you know, when you get down to 1,000, which is our minimum, there's just not enough events to fully capture the distribution of potential claims.
Isn't, Jared, I think that is like almost a reason where when I'm listening to the description, it's almost a reason to say we'd want to calculate variance at the group level, or at the, whatever you want to call it, the attributed group level or assigned group level. Because if I'm thinking this through, the variance calculated at a line of business level will ultimately be smaller than the variance calculated at the group level. Because there is more variation at the group level, we want to be able to provide the right degree of confidence that a conclusion shouldn't be drawn. And I think if we use it at the line of business level, we might inadvertently be drawing a conclusion that isn't supported because the variability at the group is so high.
Well, I mean, to me, it just depends on, did that group have large claims or not? If they don't have large claims, that group's variance, I think, would actually be lower than across the entire pool.
I mean, I think the reason that Oregon has pursued this entire confidence interval statistical testing approach is so that we get to the noise. We do get to those random events. We do see if one group had the large claims than another. That's exactly what we're trying to account for here. So I think, Jared, I think I hear what you're saying, and, you know, sort of mathematically that makes sense. But I think if the intent of the program is to tease out accountability and make sure that we're accounting for those various random events, we do want this at the group level so that we can make sure we're not inadvertently holding anyone accountable when they shouldn't be, or letting anyone else off the hook when they shouldn't be. And I think that's what Drew's saying.
Can we just play out like some simulations though, like and for a group that consistently has large claims, well, their variation would be potentially small because they're consistent. The risk is that if they had consistently had large claims in one year and then consistently didn't have large claims in another year, in maybe the base year, and so their trend looks high without large variance.
So, sorry, this is January from Baylor Health, just piping in here. I don't think it's necessarily about the claims for one, the size of the claims for one group, but rather sort of how much, you know, within that group, the individuals, how much the claims of each individual attributed to that group vary.
Yeah, I meant to say claimant, not, yep. Thank you.
And so if there's a lot of variation within, you know, on the spending of each of those individuals, that group will have a larger variance or a larger standard deviation, which would give them a larger confidence interval.
Yeah, I guess my point is, you've got 1,000 members, which sounds like a lot, but it's not really a lot in terms of understanding true variation that may exist in medical claims. And as I've looked at relatively small populations, you know, in the 1 to 2,000, or you know, certainly when you get below 1,000, you just tend to not see the variation. And so I just would suggest this is an area to look closely at. And it could be that simulating it and picking one for this first data submission and then trying to understand what does it look like if you viewed it in different ways might provide a lot of insights here.
Yeah, thanks, Jared. I do think we're going to learn a lot from this first data submission and understand how this plays out in reality. I think from a policy perspective, I think we're trying to balance, again, the charge in the original Senate Bill 889, which was include all payers and providers in the state. Okay, that's too much. We can't include every single provider in the state. So how do we sort of winnow that down with some of these size thresholds, the 1,000 members, the 10,000 member months, or 10,000 lives? How do we create some thresholds there? And then how do we ensure confidence that this was large enough, there was enough variation, and it wasn't random? I agree with you that this is not, this is not how we would design it if we were academically trying to capture the variation in medical claims for a population. But I don't think that's the problem we're trying to solve. I think we're trying to find that balance between who should be accountable and what's the right threshold or cut point for that. And it is very possible that when we go through this first cycle, there are going to be a lot of provider organizations that fall in that middle. We just cannot say anything with confidence. And I think that's kind of the trade-off of, we have a very inclusive program relative to some other states that might only say, okay, top 5 large health systems, you're the only ones we're going to measure and hold accountable. But we also have this as our counterbalance of, there's this huge gray area in the middle where we're just not going to be able to say a lot of things decisively. And I think that's, in some ways, that's by design, because we're trying to protect the smaller providers.
Or those providers with kind of the random, kind of spurious, claimant that kind of throws it off a little bit, but won't really impact the distribution so much, but would impact the average PMPM. And so that's where the CIs can really help.
So can I maybe nudge back to the question? I think, Jared, you had shared, and maybe Drew as well, that, just pick one, it doesn't really matter. Does anyone else have an opinion on that, or should OHA just make a decision and just pick one?
Yeah, this is Richard from Comagine Health. I would suggest that we use standard deviation. Most clinical studies you see reported in journals show the mean plus or minus standard deviation. It helps you figure confidence intervals. And then if you're doing continuous process improvement, they separate bands from it. Is this an expected event or a non-expected event? And it's usually based on 1, 2, or 3 standard deviation levels. I'd strongly recommend we use standard deviation instead of variance if it's not an issue for the payers who have to submit these data.
Yeah, this is Greg with Kaiser, and I agree with that. We should use standard deviation.
Great. Anyone else want to weigh in?
I see a couple of thumbs up as well.
Great. Okay, so we have OHA has some next steps to do some examples, scenarios, provide some additional details. I know another state built a whiz-bang calculator, so maybe we can do something like that to show just kind of how this applies to that line level conceptually. So we have some homework, and this was helpful. Thanks all.
Okay. Let me talk a little bit about the next steps and the request for feedback from you. On the next slide, please, Michelle. So again, we've sent out the June 3rd data submission template and specifications drafts. I think we're asking you for another round of review if you have time and capacity, and sending any additional feedback or questions that you have to us by June 18th. That will let us round up any final outstanding questions for our tag meeting on June 22nd, and then we'll finalize and publish by June 30th. And that then you will have from June 30th until October 1st to build the data submission. We'll talk more about data submission, data submitter training, and TA over the summer, but we will at least have the specifications and the template finalized. So again, please take a look if you have comments, questions, if anything in there is confusing, if you think anything in there does not reflect what you think we discussed or landed on in the tag, please let us know. We've been translating sort of between meeting materials and the documents and making sure we didn't lose anything in translation. So let us know. Any feedback is welcome, preferably by June 18th, so that we can prepare for our second June tag meeting. So we've got still half an hour left, and I just wanted to open it up. Are there any other questions, comments, issues that people want to bring up related to the specifications, the templates, the process? Anything else you'd like us to think about before our second June tag meeting? Okay, I'm not hearing anything. I'm not seeing any hands. So, OHA team, Megan, January, any final comments or questions you want to throw out?
None for me.
None for me.
All right, then we will end early. Our next meeting is June 23rd. We will send out a revised data submission template sometime after June 18th. Hopefully that will incorporate some of these comments and your feedback. Our June 23rd meeting will focus on final review, touching back on these final outstanding questions, and maybe starting to talk about validation, maybe not. We'll see how many more outstanding questions we have. Thank you again so much for all of your time and for jumping on an extra meeting this month. It was really helpful. And thanks in advance for all of the feedback that you're going to send us over email. We really appreciate your engagement and thought partnership as we work through this. All right, have a great Wednesday, everyone. Thanks so much.
Thanks, everybody.
Thanks.
Bye.